Good afternoon, I'm Dallas and I'm Director of Services here at Lymphoma Action, and welcome to our last webinar of 2022. Okay, so without further ado, I'd like to introduce you to our panel this afternoon for this webinar on having great conversations with your healthcare professionals. Wendy, could I ask you to start, please?
So my name is Wendy Osborne and I'm a consultant hematologist and I'm based in Newcastle, and I'm very keen on looking after people with lymphoma and also lymphoma research.
Thank you very much, Wendy. And Leslie?
Hello, I'm Leslie. I was a nurse for over 40 years. I ran a very small child abuse charity in South Africa, and I was diagnosed with nodal marginal zone B grade lymphoma in 2017.
Thank you, Leslie. Thank you for joining us. And Mike?
Hi, I'm Mike Taylor and I live in snowy Inverness at the moment. Diagnosed with one of the rare skin lymphomas, cutaneous T-cell lymphoma, otherwise known as mycosis fungoides. And that's over 23 years ago.
Thank you. And thank you all for joining me this afternoon for this conversation. The reason this conversation has come about this afternoon is because we recognise that concerns about possible symptoms or having a diagnosis of lymphoma can be a really worrying time for individuals and their families and their carers, and that people often say to us that they feel like the rug has been pulled from under their feet. And then we layer that with the complexities of navigating the healthcare system, of primary care, GPs, and also secondary care, having tests and getting diagnosis and meeting specialist doctors and nurses. And we hear a lot about patients being involved in their care, involved in decision making. But I think we recognise that's a little bit more tricky to do for some people than for others, and can be incredibly overwhelming. And actually being a patient can feel quite disempowering. So today we're going to hope to explore some of those issues, recognising how it can be to be in that position and to feel that way, and the impact waiting for a diagnosis can have on your ability to communicate with your healthcare team. So let's start, shall we, with having symptoms. Let's start with that phase just before you're getting that diagnosis. So maybe Mike and Leslie, would you like to, Mike first maybe? Would you like to share your experience of having those symptoms and needing to communicate that to your GP in the first instance?
Yeah, my route to diagnosis is really unusual, basically because of the type of lymphoma I have. So back in mid-1998, I went to see my great GP with a small rash on my back. No other lymphoma symptoms, absolutely nothing. My GP tried all the lotions and potions under the sun, and eventually after 9 months, he said, I give up, referred me to dermatology. I got my appointment very quickly for dermatology, and I went to see my dermatologist. He checked over my skin. He checked under my arms and my groin, lymph nodes that I now know. And the only thing he said was, you have parapsoriasis. Now, I know a lot of people with psoriasis, bad skin. No, that's okay. I've got bad skin. He prescribed some steroid creams, suggested I have a couple of biopsies, a CT scan, and some UVB treatment. So I asked him why I was getting a biopsy, why I was getting a CT scan, because have I got skin cancer? And he just said, no, you haven't got skin cancer. And he repeated it, you've got parapsoriasis. So no Dr. Google back then, which is really useful. As we know, it's I love it or hate it. I was not given any written information, nothing at all. So basically, I went for 3 years, 6 monthly checkups. I was getting UVB treatment 10 weeks a year for about 3 times a week, and various creams. And then in mid-2002, I was mistakenly copied into a letter that was sent to my GP from my dermatologist. And that was the first time in 3 years that I found out that I actually had been diagnosed with mycosis fungoides, otherwise known as a rare type of cutaneous T-cell non-Hodgkin's lymphoma. I'd never heard of lymphoma, let alone cutaneous T-cell lymphoma, let alone mycosis fungoides. Even being able to see it is pretty impossible. But by then, Dr. Google was there. And all I'll say is my next appointment with my dermatologist was very, very interesting. For those who are listening in, mycosis fungoides is a skin lymphoma, where the majority of lymphomas grow inside our bodies. Mine grows on my body, and it's visible. How did I feel about being diagnosed? Well, I'd lived and been treated for the condition for 3 years, and it was part of my life. So by the time I actually found out I had the rare lymphoma, I had got used to it. Yes, I was surprised. Then I obviously started to ask questions about MF and find out the possible challenges that could come along. And sure enough, the challenges came thick and fast in a big way. So my diagnosis was really, really unusual, to the point that I wasn't even told I had a rare lymphoma for 3 years.
Wow. Thank you, Mike. I think there's lots of things in there that we're going to be coming back to during the conversation. Leslie, do you want to tell us a little bit about your path to diagnosis?
Sure. Okay, at the beginning of 2017, I was beginning to approach a significant birthday. I won't say which one. And I thought, okay, it's time to get my life, my health in order. So I need to lose some weight and I need to get a bit fitter. So I embarked on a diet that seemed to be working quite well. And as the months went by and crept towards my birthday, I'm thinking, God, this is what I never thought it was going to be as easy as this. And by the time my birthday came along, I had lost a couple of stone. So I thought, this is cool, and I look great on my birthday and everything's fine. And then I went on holiday, and where we go on holiday in Wales, there is a very large hill, and I really struggled to get up this hill. And I thought, well, that's what happens when you get a bit older and you're going to get a bit tired, and not to worry. And I was getting some hot sweats, and I thought, oh, menopause, God, it just goes on and on and on, this wretched menopause. And when I came home from the holiday, I realized that things weren't actually terribly well. So I went to see my GP, who was brilliant, and sent me off to have an X-ray and did some blood tests. The X-ray was a bit delayed. The blood tests came back. They were all fine. They were all normal. Everything was fine. The X-ray wasn't. And when I'd had the X-ray done, the radiographer came out and said, when are you going to see your GP? Now, I'm an ex-nurse, so I understand some of these little messages that you get. So I thought, oh, okay, she has found something. And I then got whisked through the system by my GP, who said, there's something very odd on your chest X-ray, so go off and see a chest specialist, which I did, and they didn't really tell me anything very much. And there's an interesting aspect of being an ex-healthcare professional and being a patient that weaves its way all the way through my experience. And so I didn't actually ask too many questions, except, what is it and what are you going to do? And they said, you need to go to what turned out to be Harefield Hospital, and we need the lung people to have a look at you. I went to Harefield. They admitted me that day, and I had 2.5 litres siphoned off my lungs. Now, at that point, I thought, okay, I think I might have lung cancer here, but nobody's actually telling me. And I had a very good consultant who actually said, I don't know what this is. This doesn't look like anything I've come across. So I went back to the chest clinic afterwards, and they said, this is not for us. We think you might have lymphoma. We don't think you've got lung cancer. And at that point, I was really relieved. I didn't, like Mike, I didn't know very much about lymphoma, but I knew fairly rapidly that it wasn't going to be as bad as having lung cancer. And then I got referred to the hematologists, and I saw them probably 10 days later. And it was a really difficult 10 days. I didn't have anybody to speak to. I didn't have anybody to ask questions. When I phoned my GP surgery, she said, "You're seeing the hematologist next week, they will talk to you." And there's this kind of interregnum, this space where you know you've got something seriously wrong with you, and you don't know who to talk to. When I got to the hematologists, they said, "You need to have a biopsy." I had the biopsy, and the rest is history.
So both of you actually had quite long trajectories, didn't you, between feeling poorly or having symptoms and getting to that diagnosis point. Would you have done anything differently, Leslie, do you think, if with the joy of hindsight? Do you think there was a point in that part of your journey that maybe you could have felt more empowered to speak up, maybe?
I didn't recognize the weight loss for what it was. I thought this was just a great diet. By the time I'd lost 3.5 stone, I knew that something very serious was up. And again, it's this curious thing about knowing something about the health service, not wanting to bother people, feeling as if you might be making a bit of something out of nothing, because although I had a lot of weight loss and I was beginning to get breathless, there was just nothing else. Yeah, I was itching a bit. Yes, I had a few sweats, but that could have been the menopause. It's very difficult to pinpoint a moment when you can say to a healthcare professional, "Hang on a minute, I think something's seriously up here." When you get to the point that it is serious and something has to be done very quickly, it is obvious, but there's that bit before. Would I do anything differently? Probably not. No, except worry.
Yes, indeed. Indeed. So, Wendy, when people come to see you as the consultant, do you recognise some of those things that Mike and Leslie were saying, that it's been for some people a little bit of a path? They've been to see different consultants, they've had different views and stuff. Is that something you recognise in practice?
It certainly is, and I think that Leslie and Mike have highlighted that with lymphoma, because it can affect any part of the body, because the symptoms are so varied, often there can be quite a delay in actually presenting or getting a diagnosis. And I'm very lucky in the sense that because I'm a specialist, everybody I see often has already got a diagnosis or is a very high suspicion. Whereas for GPs, for example, they will see 500 patients with a rash, and probably less than one of those will have a skin lymphoma. Yeah. And the same with people presenting with weight loss and sweats. I mean, I get referred a lot of people with sweats. I would say that almost most of them do not have lymphoma, because there is lots of other causes for some of these, quite especially if there's subtle, not 3.5 stone, but subtle weight loss. So I think that there's because of the nature of lymphoma, and because there are more than 60 different subtypes and it can affect everywhere, it's quite common, the stories that I'm hearing here from Leslie and Mike, because most people end up not having a diagnosis of lymphoma. And I think that this is where it's really important for us as health professionals. So when Leslie described that 10-day wait, I think that's really difficult for patients. And when Mike talked about Dr. Google, I sort of did an inward gasp, because I sometimes think that Google can cause more harm than good. And when I say to my patients in clinic, if you want more information, please go onto the Lymphoma Action website, because I know how accurate the Lymphoma Action website is. What I try to say to patients between that trying to get a diagnosis and firm diagnosis is to stress the importance of making the accurate diagnosis. And that although there's that anxiety and worry in that several week trying to get the histology, if we can manage to make sure that we know exactly which subtype, then we can select exactly the right treatment, and that will give us the best outcome for our patients. But that's really important communication that must come from health professionals. And also I do find that I know that Lymphoma Action provide that support as well. So I think that these diagnoses, it's quite, my patients that present with a big swollen lump in their neck usually get diagnosed very quickly. They see their GP, big neck lump, biopsy, that's it. It's the patients with the unusual skin rash with a very rare skin lymphoma or non-specific weight loss that it takes longer.
Yes, yeah. So is the message there that if we feel that there is something not right with our bodies, then we should be going and having those conversations with our GP quite openly, and when we feel it's the right time to have those conversations with our GP?
Yeah, I think so. And I think it's sort of recognizing if things are getting worse, that's when I would always, and GPs usually do the safety netting. So if things aren't getting better, then do come back. And I think that, you know, I'm very mindful that, you know, GPs see so many patients with symptoms that end up they do get better, and they don't end up having an underlying cancer. And we know that we couldn't scan every single person with a symptom that might not improve. So I think that my sort of message to patients would be, lymphoma doesn't come and go. Symptoms of lymphoma, if you've got them, then they get there and they continue to progress. So if you've got abdominal pain, for example, but one week it's bad and the next week it's okay, that would be less concerning for me that patient has symptoms of their lymphoma coming back. So I obviously see a lot of follow-up patients. Whereas if things are present and progressing, then yes, I think making sure you contact the health professional again.
Leslie and Mike, coming back to you have a diagnosis, you're going to go and see a specialist. How did you prepare? How did you prepare for that meeting with your specialist? Because this can be an emotionally overwhelming time, can't it? And to get the most out of that first meeting, can you think of anything maybe that you did well that worked, or maybe some strategies you wish you'd had at the time to make the most of that initial meeting?
I think there were two crucial things for me. One of which is take somebody with you. And my husband came with me and knows me well enough that he sat quietly in the background, but we had talked about the things that we wanted to ask, and he knew that if I forgot any of them and I didn't ask them, that he would step in and he would ask them, because we had worked through the things we really wanted to know. Some of it was really tough stuff to ask, because the tough stuff comes up in your head. And for me, I really needed to go down that route, and I really needed to ask those questions. And he knew to ask it if I didn't. So having him there was really good for me, sitting beside me and knowing that he would have my support and confidence to ask things. And the other thing was going through this list of things to ask. People always assume, and I'm not being rude about anybody, but people always assume if you have a health background that you're going to have confidence and that you're going to be able to ask things, and that you're not going to stutter and you're not going to forget things, and you understand the terminology. And all I can tell you is that when it comes to yourself, and when it came to me, whoa, it was just so different. You know, the ground goes out from under your feet, you forget everything, you stumble, you can't remember any of the right words to use, the body becomes a complete mystery, and you almost feel as if you're going, I don't know what to say. So having a list of things that you've worked out beforehand that you really want to know, and making sure you go through them and that you've got the support of somebody that you trust with you, who's with you, and who can say afterwards, no, that isn't actually what he said or she said. Actually, this was the way the conversation went. It was so important. It really helped to get me on a stable, steady footing for the next stage.
What about yourself, Mike? How did you manage that?
Yeah, well, obviously I had a really bumpy start because it took 3 years to find out what was actually going on. So I knew the nursing staff better than my dermatologist, and he was quite a stuffy, old school dermatologist to the bow tie and talked over his glasses. So it was an interesting development in getting myself in a position to be able to communicate with health professionals, because I was coming from the back foot, really. I'll tell you a funny story, that I knew the nursing staff and the dermatology really well, and I was getting ultraviolet treatment 3 times a week, and I bumped into one of the staff in a restaurant one day, and she turned around and said, "Oh, Mike, I can't recognise you because I didn't recognise you because you've got your clothes on." That was in front of my wife, obviously, but so I never had that opportunity to really get stuck in. But when I got that accidental letter, then I was able to then put initiative in place to sit down, cross my arms, and, as Leslie said, get the questions out and get them asked. And it's really important. My GP was shocked that I hadn't been told, and I hadn't seen my GP for 3 years in that interim period. So he couldn't believe it. So he was quite shocked. But that 3 years experience, and then having to develop a strategy, I call it the big feet, pointy elbow strategy, to get information, really helped me, because I then went on to have umpteen appointments with different departments: oncology, hematology, stem cell transplant, radiology, audiology, respiratory, cardiology. So over the past 20 years, I've had all those enormous amount of different consultants, and I worked on the same principle, that be decisive in the questions you want to ask, have your top questions, and do not leave until you get answers for them. I found that really important. So yeah, it was just developing a strategy.
Yeah. And Wendy, from your point of view, obviously you see lots of patients, and I assume they're all going to come in different states of readiness to have those conversations. What sort of things, from your point of view as the consultant, make those meetings go well, get the most out of them?
So it's made me feel sad that Mike said that he needed to have big feet and pointy elbows, because I think that unfortunately that does happen sometimes, but I think it's our duty that we need to be communicating clearly with our patients and their families. And I think that the discussions will depend on whether it's a at diagnosis discussion or whether it's unfortunately, you've got relapse disease discussion. I think that the most important thing for me for my at diagnosis was the point Leslie made about having someone with you. And I have patients come in and often with a partner, and then I'll ask them if there's anyone else with them, because sometimes they have their children in the waiting room, and I'll go back out to the waiting room, and if the patient would like, have everyone in the room at once, because we know that sometimes things change when the explanation happens, and it's so much better to all have one consultation. Now, obviously, that was more difficult during the COVID-19 pandemic, and I found that one of the hardest aspects of the pandemic was having to see patients often without their family members. The second thing I think that's really important is, as has been pointed out, is the list of questions. And I think I quite liked Mike's point about having the most important things at the top, because that's what we really need to focus on, because sometimes the discussions can spend maybe too much time on small nuanced things that aren't as important, and then miss the big things. So I encourage my patients to write a list. when we have a at diagnosis discussion, I mean, I'm lucky I work with, I would argue, the best clinical nurse specialists in the country, and they are always in the room. If possible, they have the direct number for my patients to ring them. And I know that patients will go back a day later and ring about things that they were worried about. I think that the point, and again, it's disappointing to hear about this letter that Mike described. We now, as you know, copy the letter to the patient as well as to the GP. And I think that's helpful. I think that the problem with it is that the letter initially was always done as information for the GP. So a lot of medical terminology is used, and sometimes that can be more difficult. What I've started to do in the last couple of years is that I actually dictate my letter whilst the patient and their family are in the room with me. So that then I say to them at the end, because it was going to land on their doorstep the following week, is there anything there? Have I not explained anything properly? You know, this long word means this, and I just do that now in the room, and I found that has been more helpful, and I think my patients prefer that. So I think that the somebody with you having a list, sort of being clear about the letter, I think there's too much to take in on that first appointment, and so obviously it depends on whether that's trying to look for information. Are we going for biopsy or to tell the person that they have a type of lymphoma? Our patient, we always send away with written information about, we give a lymphoma action booklet about the subtype of lymphoma and written information about the planned chemotherapy, and then give a follow-up appointment the following week later to go through more questions and consent. Because during that week is when all of the questions are properly going to come out. Because the final point is, I have to give a certain amount of information to make sure that I feel my patients have got enough information to consent to chemotherapy or radiotherapy. At a time of relapse, which is a more difficult conversation, I think that it's really important to try and judge what the patient wants to know at what point. So Leslie talked about having some difficult questions that she wanted answers to. There are some people that don't want to hear certain things at certain times. And so I'll always sort of go in and say, you know, I will ask the patient what they want to know. Some people a relapse situation, don't want to know prognosis. Other people want to know all of the latest data and published median progression-free survival curves. Everybody is different. And what we need to do as health professionals is to give the information that the patient wants, with the backup of a specialist nurse and the backup of Lymphoma Action, so that they're not having to use Dr. Google, where I don't trust a lot of the information on the internet.
So it sounds like that it's important to come prepared for those meetings, but also if the patient feels able to understand what their own boundaries are and what they do want to ask and what they don't want to ask. Yeah.
Yes, I think so. And I think the other thing that's interesting, so sometimes I'll have a relative want to know straight away, so what are the chances of cure? And you can see that my patient isn't ready to hear information like that. So then I'll just go back, because obviously, as much as I want everyone in the room, the patient is the most important priority. And therefore I will say, do you feel you want to have this discussion? Or, you know, because everybody has different needs. And I find that sometimes partners or children want more definitive statistics, and my patient just wants to know about what's going to happen to them, whether they're going to lose their hair, how long the treatment's going to take. And you can't, doing too much information in one go is sometimes more harm than good.
I mean, I appreciate Mike you've been in the system for a long time, Mike, so you had a sense of what your most important questions were. All I can say is, coming into this whole scenario is that I knew the questions I wanted to ask, but I didn't know what the most important ones were. It's only as you go through the conversation that you begin to get a sense of what some of the most important questions are. And then you come out, and if you're going to tell your relatives, I mean, I decided I would go and tell my children personally. So I traveled around and I told them personally, and they began to ask questions. that I hadn't thought about, so I began to store away because of the nature of lymphoma and because of the essentially non-curative but entirely treatable nature of it. People don't always understand why you don't go straight into a lot of treatment. And I have learned I'm a Live Your Life facilitator for Lymphoma Action, wonderful organisation. And I hear again and again the difficulties that people have of talking to their healthcare professionals about why they're not having treatment. They've got cancer and they're not having treatment, and having to try and kind of hold the ring between relatives who don't quite understand why they're not having immediate treatment and talking to their healthcare professionals. So you're a bit between, it's not quite a rock and a hard place, but you're the patient, and yet you're having to kind of hold your relatives' anxiety as well as, and your friends' anxiety, as well as trying to understand what's happening to yourself. And it's really quite difficult when you're sort of absorbing what's going on with yourself at the same time. And it's just, you know, to have the confidence to ask all these questions when it's all going around in your head and you've got upset relatives and you don't quite know what's going on, and Google's telling them one thing, and it's tough. It's really tough.
So Leslie, I think you've mentioned a really, really important point there with the active surveillance or watch and wait, because how common is it that you say to someone you have cancer, but you're not going to do anything about it? And obviously for me, there is clear evidence and I understand why we do this. And I say to my registrars that we need to be spending as much time with our patients who are on an active surveillance or watch and wait approach, because what we don't want is for, you know, the 20% of patients who never need treatment actually to be unwell mentally because of the anxiety associated with this. Well, why aren't you doing anything about my cancer, doctor? And I think that we as health professionals need to explain that to patients. But if I'm honest, that's where for me the Lymphoma Action team and website is really helpful, because when my patients say that they've read and then connected with other patients who are on a watch and wait approach and realize that they're not being neglected, that actually it's for the benefit, because we know that is the right way to treat a low-grade lymphoma. But it's up to us to make that communication, because as you've said, for your family not understanding why, because everything we see on the news and in the newspapers is early diagnosis and early treatment, and yet for a low-grade lymphoma we do completely the opposite for the right reasons, but only if we explain that clearly to our patients.
That's a really good point, Mike.
Yeah, it's fascinating. I help out in our Lymphoma Action's closed Facebook page, and it's remarkable the amount of people that join the group who have been diagnosed with a low-grade lymphoma, and they're on active monitoring, and they think they are the only person in the world that has actually been told that. And then after 24 hours, they've got 30 odd replies saying, yeah, it's me, it's me, it's me. I've been there for 10 years. I've been there 15 years. And it's amazing that peer support comes together and helps people understand and unpack. So yeah, a little flag for the closed Facebook page. There's an excellent list of questions in the Lymphoma Action site about questions to ask your consultant. That's a very good resource as well. I was on active monitoring basically for 14 years. Yeah, I was treated as though I was having bad psoriasis, because that's what it looked like. So I was getting ultraviolet treatment, but it took 14 years for my condition to become aggressive, very aggressive. And so I understood the importance of not treat. I got to understand why it was important not to go in with the big guns blazing, because I ended up 2015 having by 2015, having had 2 allogeneic stem cell transplants. The first one didn't work. It failed miserably, but there was always a plan for a second one because we were trialing a conditioning that, if worked, I would recover really quickly. Unfortunately, it didn't work. I know others it's worked for now. So my second one was a full-on treatment. But looking back over the 14 years and speaking to other people, my skin's perfect, and it's been perfect for 7 years. I've got no lesions, nothing. Some people will say, well, why did they not just do the stem cell transplant? I said, well, there's a balance here. I was 44 when I was diagnosed. I was 60 when I had my stem cell transplants. And I went on to have a catalogue of other issues because stem cell transplant brings along other issues. With the worst one having a heart condition and actually having a heart attack back in April. But 2 stents later, I'm fine. But don't go in with the big guns blazing because it could be counterproductive. Because I lived and worked for 14 years, well, 12 years with just simple maintenance treatments being observed and looked after. So it's a balance. It's a real balance.
Yeah, and that's why we're having this conversation, isn't it? Because it comes down to great communication. If you have great communication with your healthcare team, then you'll understand those reasons, and hopefully that will help you to have that conversation with family as well. Wendy, we've had a couple of questions which have been about, there are times where I don't think I should bother the doctor, or times where I don't feel like I should bother my nurse because they're very, important, busy people. I mean, do you get a sense from some patients coming in that there's something they want to ask and maybe they just don't feel they should?
Yeah, again, and I think that's, we have to, as health professionals, take responsibility for being accessible and making us being open to questions. And I think that certainly there are the 2 aspects. 1, the discussions and communications, and 2 is the action. So when I'm giving somebody chemotherapy and I have some people who don't want to bother the doctor and therefore don't ring us when they've got a temperature, that's when I'm very clear and explain to my patients that any of these symptoms, even if you're coming up to hospital the next day, even if it's 3 o'clock in the morning, and you have a temperature, you must ring us. So I think that we need to stress that there is not any bother, and it's actually important to communicate with us with any physical problems. And we need to have that ability to be open for any questions and discussions. So I think at times, you'll have, I know that Leslie and Mike will have sat in many outpatient clinics that are running 2 hours late because things go wrong and some patients are unwell, and I think that what we need to do as health professionals is make sure that we still have the time for people when they have questions. And it might be that if you think that your questions are minor, then it could be that you say that I have got some questions, I can see you're running 2 hours late, is it possible to make time to speak to you about them next week? And then your health professional is aware that there are things that still need communicating about, but not making you feel under pressure that this is maybe not the right time. Obviously, if there's something that's causing a lot of stress and anxiety, you just need to go ahead and ask the question. But it's a 2-way thing. And I think that, whenever we do our training and for our junior team, these are important things we discuss. And I think we're lucky that more and more specialist nurses, our specialist nurse, they work at a level of a consultant, and they are directly accessible to our patients, and they are able to answer pretty much everything. And if they've got concerns, then they'll ring me and ask me to ring my patient, or we'll see them in clinic the following week.
Yeah, so I was going to ask all 3 of you actually, do you, obviously your relationship with your consultant is paramount and incredibly important, but would you all advocate for building that relationship with the nurse specialist team or somebody else as well within the multidisciplinary team? Leslie, you're nodding your head.
Yeah, absolutely, I would. They are the first point of call. And Wendy was talking about this is a 2-way thing. one of the things I now feel really strongly about lymphoma is that as patients, we need to understand what it is that's happening to our bodies and to ourselves, because we're in this for the long haul mostly. It is a chronic condition that we're going to be living with for a long time. So we need to work hand in hand with our clinical nurse specialists and our consultants, and to understand enough about what's happening to ourselves so that we know when we can have the confidence to pick up the phone or to send a message or to say, do you know, I don't quite think things are right here. I'm not quite sure what's going on, but I think there is and to have that confidence and security to ring, firstly, the clinical nurse specialist. There are so many patients and so many times in life that I've seen as a nurse where we kind of hand ourselves over to the health service, because on this occasion with lymphoma, we are dealing with this long-term condition. We have, there's almost a greater responsibility on ourselves as patients to take a bit of personal responsibility and to learn about and to have confidence and to say, actually, I know my body quite well. I might not be an expert on all lymphoma, but I'm an expert in myself, and I know that things are happening and I just need to talk to somebody about it. And the fact that they're there on the phone gives huge confidence to the fact that we can do this. So we might well let things go a bit longer because we know that they'll be there to pick up some pieces, or to say, it's okay, Leslie, you know, you're not going down a dark hole. This is fine. This is what happens to bodies as you're aging, or as things go along, or maybe you pulled a muscle, you know, whatever it happens to be. But they're there. Yes.
Yeah. So really important to build those relationships. Wendy, somebody's asked us about the liaison between primary care GPs and specialists, and whether or not the communication between you as the consultant and the GP is key, or whether actually conversations are better to have with you and the CNS than the GP.
Yeah, so I think it really depends on what the problem is. So how I always say is that for any lymphoma related problem, we would rather our patients just come straight to us and our clinical nurse specialists. And so for most of my patients sort of going through chemotherapy, if in doubt, I'd rather that they came to us, because I think that's important. As Leslie's pointed out, there are a lot of people who have, you know, a low-grade lymphoma as a long-term condition, and so therefore, I mean, you wouldn't want me managing your blood pressure. I am not up to date in optimal hypertension management. You wouldn't want me managing depression. I am not up to date with this. And I think that there are so many other skills that GPs have, whereas I'm very narrow-minded and only know about lymphoma. So I think that what we need to do is I think everybody has a role in terms of between primary and secondary care. I think sometimes in secondary care, we aren't, I'm speaking about myself mainly, I'm possibly not good enough at speaking to GPs often enough. We get very close to our patients. We look after them a long time. Even this morning at work, I've had the husband of one of my patients come in to see me. I'd looked after his wife for a long time. She was a young woman, and I sort of see her as my patient, and I should be ringing the GP as well, because obviously the GP is looking after often the whole family. So I think that really focusing in on probably seeing the hematologist first for anything that could be related to lymphoma or chemotherapy. If it's not clear, then see the hematologist, but otherwise seeing the GP. And if your hematologist isn't liaising closely enough, they'll be getting the letters, as I said, but about, you know, possibly you feel that about prognosis, then asking your hematologist if they would just give your GP a ring. And I'm trying to do better with that and do that more.
Yeah. Mike, you said you hadn't seen your GP in several years. So did you feel that you just struck up a relationship within the hospital? Or Do you think in hindsight maybe the GP should have been kept in the loop?
Probably the GP was kept in the loop, but I wasn't going to see him, so there wasn't in a conversation. And I know the GP really, really well, to the point where we became friends over the years. So once the whole lymphoma badge went on my chest, and he understood that I now knew, or I didn't know, it was a different approach, to the point that he used to phone me up and ask me to come into the surgery when they had students in, it's a show and tell, and sit me down and get the students to say, well, figure out what this man has got. Mike will be quite happy for you to poke and prod, because there's a good chance you may never see a person like this with this condition in your whole life. And it was even the same with specialists, dermatologists. I went to a Scottish Dermatology Society get together, and out of 80 dermatologists, only 3 had ever seen my condition. So it's building up that relationship. But again, picking up on Leslie, it's important for everyone to try and understand their specific type of lymphoma, to understand it, to speak to their specialists, to get an understanding of how things will go, because it's important to separate normal life conditions and what is lymphoma-related conditions. And if you get that nailed within reason, life will become less stressful. And often that needs to have good communication with the specialist nurses, and my one was brilliant. I can only say that. Called her my mother hen, and she used to give me waggy fingers when I was not behaving, or got a pat in the back when I was behaving. But it's all communication, and it's getting to know people. When I was getting blood tests done in the early days, once I went to hematology, I used to speak to the nurses and talk to them and ask them about how long they've been in nursing, and use their first names, because I was so aware, having been in a ward for over, I think it was 142 days in total over 2 years, that nurses get a bad deal being shouted at, nurse, 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 and they've got their names written there. And I made it a mission to appreciate nurses and to call them by their real names, and to support them. You become a nice patient, which can help. It really can help, because you get more communication that way. I'm not going to say you get blanked off if you shout at the nurses, but it's really hard. It must be really hard for them.
Yeah, I think there's a really key link there, isn't there, between, over time, as you say, building a relationship, and then that relationship helps you to have more open and honest conversations. And those questions you weren't really sure you wanted to ask before, you maybe have the confidence to ask after you've established a little bit of rapport and a little bit of more trust in that relationship, isn't it? Because there has to be a trust relationship going forward. Wendy, somebody has asked or has said that they are still being offered video and telephone conferences and would really, really like face-to-face consultation. How should they approach maybe getting that point across that they'd really like to see somebody face-to-face?
I think I would just ask. I think that now that we've certainly opened up, I mean, to me, I say to my patients, it doesn't make any difference to me whether it's a telephone call or a face-to-face. I have some people that hate trying to get parked at the hospital, and there are some people that are very keen to come face-to-face. So I think just being honest, and I don't know the reason what means in some centres. I mean, we're often very happy to follow up our well patients by telephone, the ones that we're worried least about. So that can be quite a good sign. But I think I would just ask, and I think nowadays it may be that you can work out with your team the optimal way, and maybe they see you face to face every other appointment and telephone appointment. I think the important thing we also need to recognise is that what I'm realizing, especially with mask wearing, which we're still doing, is that a lot of people's hearing isn't perfect, and they find telephone consults very difficult. And so I think it's important that we don't assume that it works for everybody. Some people don't have good Wi-Fi connections, so a video consult doesn't work. So I think just being open and honest, because it's possible your team don't even know that you want to see them face to face.
Yes, yeah. I think it's a little bit that Leslie was alluding to. When we become a patient, we kind of lose that courage and that skill in stating our wishes, don't we? And I think maybe we need to hear that it's okay. It's okay to say how we feel and what we want from a situation, isn't it? And we've just had a question come through, which is related to all of that, and that's the impact psychologically and emotionally on our mental health when we have a diagnosis of lymphoma for today's purposes. Leslie and Mike, the person is asking sort of, what strategies did you employ to look after your mental well-being, and were you able to ask for that help? And if you had any hints on asking for that help that isn't physical, but it's more emotional.
I was very aware right at the beginning that this was going to be a bit of a struggle for me, and that I was going to need some help and support. And for my mental well-being, once I'd understood about the progression of lymphoma, that there was going to be periods of treatment, possibly active surveillance, and then possibly, however long each bit goes on for, but this was for the long haul. And I spoke to my clinical nurse specialist about it, and she said, I'm not a counsellor, this is not what I do. It's not what I was asking her, but she was very straight. If you need this kind of help and support, we will support you as much as we can through the physical aspects of your lymphoma. But if you think you're going to need further support in terms of a counsellor, then this is not what we do. And I was really glad that I'd asked that question, because it gave me the freedom to know that when I wanted to access it, which I did later on, that I would not go to the hospital, that I would seek some alternative means of therapeutic support. And I found myself and I still go and see her periodically, I found myself a therapist. And I'm fortunate that I found the person that I found who is used to having as her patients people who have cancer. So she's used to all kinds of aspects. But I was aware right at the beginning, once I knew that this was going to be the long haul, that I might need some support. And a lot of that is because of my family are wonderful. I am blessed with an amazing family. That they were going to worry about me, and that I was going to have to try and give them some support because of the nature of the illness. And my husband, who I had to stop looking at Dr. Google, and because he's a male, he likes information, and that they would need a bit of help and support. So internally, I was going to need some support. So yeah.
Yeah. What about yourself, Mike? Were you able to ask those sorts of questions?
Yeah. I'm a very logical thinker, so I took it really in my stride. There's not much phases me, and I've always said, until I've got something to worry about, I'm not going to worry, and that's worked for me, because 23 years of things going wrong, more and more and more, than having a stem cell transplant and being told it didn't work. That's a big blow. Having had a pretty challenging month in hospital and then have to go through it again. So psychologically, I really was quite strong. But once I was finished my treatment, and I was speaking with other friends who were diagnosed with their type of cancer, they died. And then it struck me that I actually had survived. And then the whole thing of survivor's guilt kicked in. So I was marched across the road from the the haematology unit by my clinical nurse specialist, and she sat me down in a seat in the Maggie's Centre, and she basically said, right, we're going to deal with this. And sure enough, Maggie's was great, and we unpacked. I speak about the rucksack we carry around on our back with all the stuff, and we sometimes have to take it off and empty it in the ground and get rid of some of the rubbish. We can't get rid of it all, but we can gradually get through some of the stuff and work through stuff. We can't live in denial. We have to actually accept that we need to deal with things whenever that is.
Thank you, Mike. And Wendy, one would assume that healthcare professionals are really happy when patients ask those sorts of questions about, you know, where can I get some support for my mental health and my well-being?
Yeah, I think it's really important. And I think that, you know, we have a clinical psychologist attached within our cancer unit. We've got a Maggie's Centre, which, as Mike has said, is so valuable. Our specialist nurses do as they can, but as Leslie said, they aren't trained counsellors. Most of them aren't. Occasionally some have got dual training. I think it's really important. And then the other thing to point out is that I think that we see more problems with, I certainly see more problems with mental health related concerns when people have finished treatment. So they have gone through their 6 months of intensive treatment and physically been through the mill and in with sepsis and really struggling, but they have been coming up to appointments twice a week, coming in for a review. And then suddenly we do the scan, everything looks great. We say, we'll see you in 3 months. And I see particularly my teenage young adult patients particularly struggle during that time. It's almost like a post-traumatic stress disorder. They've been through so much, but not had time to consider everything because they're just trying to get through each day. And we must recognize it. And some of my, particularly I look after quite a few teenage young adults, but young men who don't want to talk, even they've said to me, by me explaining to them that it's common that we see this particularly after treatment, and they recognize that there's nothing wrong with them and they're not unusual. That seems to have helped them, even if they haven't gone on and gained additional support. So it's such an important part of looking after our patients.
This has been the most incredible hour, but just before I wrap up, and I think we could talk all afternoon, but just before I wrap up, could I ask each of you for just a take-home message for those people that are watching and listening today? Just one little nugget that you would give them for communicating with their healthcare professional. Wendy, can I start with you as the healthcare professional?
So for me, having had this discussion, which I've also found really useful, I think it would be, please ask. So you've said one of your questions is, I'd been giving telephone appointments and the patient wants to come face to face. If I thought that my patients weren't happy with things that we planned just because we hadn't realized that they weren't wanting that. So just please ask. And if your questions can't get answered then and there, say, when can I make that appointment to see you? So just please ask.
Thank you. And Leslie, what would yours be?
Have confidence in yourself and your healthcare professionals. Ask whatever questions you want. Don't put things on one side, and have confidence in yourself to know what it is you want to find out.
Fabulous, thank you. And Mike?
Yeah, I think it's very important to try and control the battle between the ears. I think that's so important. So unloading stuff is important. So do call the medical professionals when you're unsure or concerned. But it's important to learn to live with our lymphoma. That is important. And not let the lymphoma define us. We need to define how we live with our lymphoma and not let it control us.
That's lovely. That is lovely. Thank you so much, all of you. I am going to have to bring this webinar to a close. If you have any more questions or this has raised something for you today, or as you watch this video, please get in contact with us at Lymphoma Action. Get in touch with the helpline, give us a call or an email or a live chat, and we'll do our very, very best to support you going forward. Thank you so much to my amazing panel. Thank you, Wendy, Leslie and Mike for sharing your experiences and your knowledge and skills. That's just been the most wonderful webinar, and I hope everybody has taken something away from that. But I'll say goodbye for now.
Bye.
Thank you. Bye-bye.
Bye.
Bye.